So thank you for joining us today. My name is Katrina Hernandez, and I'm an engagement specialist with OPEN, the Overdose Prevention Engagement Network. Welcome to today's webinar, Updated Guidelines for Hepatitis C in Patients with Substance Use Disorder. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work, CE, and MCBAP credits for today's webinar. We'll have a slide up with information about obtaining these credits during the Q&A portion of the webinar. We will also email the continuing education credit information after the webinar today. As I said, my name is Katrina Hernandez, and I am an engagement specialist with OPEN, the Overdose Prevention Engagement Network, and I will be moderating the webinar today. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers with our addiction medicine experts who provide guidance for managing patients who have substance use disorder or complex pain and can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. All of our webinars offer free CME, CEU, and MCBAP credits, and for prescribers, all of our credits also qualify for the DEA required SUD training. We provide MOUD training for physicians, and this year we are incentivizing primary care providers with $250 to complete one of our MOUD trainings to encourage confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all of these services more directly using these QR codes or visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable education materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants. And we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. For overdose rescue support, we also fund implementation of naloxone vending machine and distribution boxes and naloxone administration trainings. These trainings are offered as live, virtual, or free online training courses. No planners, faculty, or others in control of content, either individually as a group, have relevant financial relationships with ineligible companies. And now to introduce our presenter today, Dr. Pani Peru-Masuela is an associate professor of medicine at the University of Michigan and the Ann Arbor VA Health System, and a health services researcher focusing on improving access to care for patients with liver disease. Her research focuses on the development of clinical and behavioral healthcare models to identify and address system-level barriers to viral hepatitis care within underserved and vulnerable populations. In 2020, she joined the steering committee of the Michigan Department of Health and Human Services Hepatitis C Virus Elimination Plan, which informs policy and practice to mitigate the spread of viral hepatitis. She also works with Open on outreach and training initiatives aimed at increasing hepatitis C screening and treatment by primary care providers in rural areas of the state.
Okay, so yes, I've been part of the Open team, mostly helping with Hep C cases. So I'm so glad you included that QR code in the introduction. You can use that to submit hepatitis C cases to us anytime, along with other, opioid-related cases you might have. I don't have any relevant financial disclosures. This is the general outline for today. So to start with just talking about U.S. hepatitis C prevalence and elimination goal progress, try to talk about gaps and barriers to help frame what's new in testing and how it can be leveraged for test and treat options, and then really spend some time on updates to the guidelines that have been presented at a couple of the national meetings recently. So we certainly know we have the tools to really eliminate hepatitis C. So I think we still are grappling with the question of why haven't we solved the problem? So we know how to prevent, diagnose, and treat, but not everybody with this infection has been reached, so gaps remain. There's still a lot of stigma and discrimination for patients and people living with hepatitis C and opioid use disorder. But there are some things that are new that are worth highlighting, particularly in the testing space and how it can be leveraged in treatment, and really how we need to focus on various settings with some of these new advances and still keep our eye on prevention. And so what I would argue that if you take one thing away from this talk today, it's that we need to achieve Hep C elimination is that we need to continue to keep the foot on the gas so that we can keep this effort going. So we know that the estimated prevalence of Hep C infection in the United States based on data from NHANES, the latest sampling frame 2017 to 2020, is roughly around 2.4 million persons in the United States living with hepatitis C infection, but it might be actually as high as 4 million plus individuals. Between the years of 2000 and 2019, we certainly saw a lot of treatment happening. Over 1.357 million people were cured. But this has unfortunately been countered by over 900,000 new infections during this time period. So I think the thoughts around just trying to treat our way out of this are not where we have to stay focused. We have to stay focused a little bit more broadly. So scaling up treatment, but then also addressing how do we do a better job of reducing new infections. And in 2022, the prevalence was unchanged as new infections continue to outpace cures that we're seeing. And so when we think about national goals and progress towards these goals, we are now finally starting to move toward our annual target, but it's not met when we talk about reducing estimated number of new hepatitis C infections by 20% or more. And we are now finally starting to meet and exceed our annual targets around reducing overall hepatitis C related deaths by 20% or more, which is certainly a great thing to finally see. But I think, again, thinking about where we need to stay focused is super important here in order for us to get to the point where we can eliminate hepatitis C. And when we think about testing and treatment and where the gaps are, we certainly know among those who are infected, RNA or viral testing is still lacking in our populations. And then among those with infection, getting patients to cure is still a pretty sizable gap that needs to be addressed. And you'll see in that slide, actually, this is data from Quest Laboratories, so it's not the entire US population, but based on testing data from a major laboratory provider. And when we look at trends in the United States of hepatitis C treatments since the introduction of direct-acting antivirals after 2013, 2014, all the way through 2023, this was data that was published or presented at the liver meeting in San Diego last fall. So using a national database of pharmacy claim data between 2014 and 2013, the authors here were able to identify the number of direct-acting antiviral treatments in the United States. And what you can see is over 980,000 people have been treated. And what you can see to the figure on the right is that we've unfortunately seen a plateau in the number of persons treated since 2021. But some additional encouraging trends was seeing an increase in the number of younger persons treated since 2014 and an increased number of treatment paid by Medicaid since 2014. But we also know that access to timely treatment remains a major gap. And this is data that was published by the CDC a couple of years ago, looking at Hep C treatment within a year of Hep C diagnosis among continuously insured adults. And it's broken down then by insurance between the years 2019 and 2020. And what you can see is that 77% of people who are insured with Medicaid are not treated in this timely way. 72% with Medicare are not treated, and this is greater than what we see with private insurance. But even with those that are privately insured, we still have a sizable gap of 2/3 of patients not getting treated. And so initiation of treatment is a problem, but then Hep C clearance is also overall still very low, with 1 out of 3 being cured. But it's particularly problematic and lowest among younger adults and among those that are younger, that are adults without insurance. So again, if you think about what are all the barriers to hepatitis C treatment that we still see in the United States, this is a list of some of them. Certainly lack of awareness, stigma, reliance on a 2-step diagnostic testing process in many settings, the high cost of the medication, insurance coverage gaps, insurance treatment restrictions, treatment not being co-located, so it really requires patients to take steps, and these steps can be very challenging for our patients to navigate. And then we still have lots of populations where we haven't done enough work to reach them, to think about how do we improve treatment. So over the last several years, there's been a call for a national strategy to help us achieve hepatitis C elimination in the United States. And so this national plan, which was developed with advisors to the prior administration White House and is still being considered and under review currently, is really a national plan that would ensure access to diagnostics as well as direct-acting antivirals. And the budget proposal for this plan, so this would be a funded plan, which is when you look at global Hep C elimination progress, funded plans are able to do more, obviously, but this funded proposal would be in the amount of $11.3 billion over 5 years is what's been proposed. And over 10 years compared to the status quo, the initiative is modeled to avert over 20,000 cases of liver cancer or HCC, more than 49,000 cases of diabetes, and 25,000 cases of chronic kidney disease or CKD. It's also projected to avert 24,000 deaths, adding over 220,000 life years. And over 20 years, the health benefits would increase by more than 2-fold and cost savings by 3-fold. So where are we today? So we now have universal adult Hep C testing recommendations in the United States that have been endorsed by USPSTF with a grade B recommendation for several years now. And this recommends screening at least once in a lifetime for all adults 18 years of age and older. Also includes hepatitis C screening for all pregnant women during each pregnancy. And then in addition to this, still thinking about all persons with ongoing risk factors, including injection drug use, and testing them periodically while risk factors persist. And what we've seen in this last year, which is an exciting advance, has been the FDA approval of marketing of our first point of care hepatitis C RNA test. And this is the Expert hepatitis C test that runs on the CLIA-waived Gene Expert Express platform. But it brings hepatitis C nucleic acid testing to the point of care. And so with a finger stick that gets then, blood drawn, sample loaded into the cartridge for nucleic acid testing. The test takes about 60 minutes to run. A positive test may result in as soon as 41 minutes. And what you get is a qualitative test result. And the major advantage here is that this newly authorized point-of-care hepatitis C RNA test can help us improve diagnosis and treatment, particularly in what we would consider point-of-care settings. So which settings are optimal for point-of-care hepatitis C RNA testing? Certainly settings where there's a high prevalence of infection, lack of phlebotomy or other laboratory testing, and really thinking about leveraging this as a tool for brief or episodic encounter spaces, and hopefully leading to immediate treatment at the same time. But what we also know is that point of care RNA testing has costs associated with it, and that it's cost effective only if it's linked with high treatment initiation. And so this is data published by the Australian group, which has really been a country that has led the way in terms of hepatitis C elimination and even microelimination efforts. But they looked at the threshold analysis of equivalent cost per treatment initiation for point of care treatment. And what they found was that in various, again, high prevalence settings of prisons, syringe service programs, and opioid use disorder treatment programs, increasing treatment initiation rates to between 67 to 91% with immediate point of care Hep C RNA testing is needed for the higher cost point of the Hep C RNA testing to be the preferred strategy. So again, a really great test that can be leveraged in certain settings, but really needs to be coupled with high treatment initiation settings to be cost effective on the whole. So there's been lots of focus on test and treat opportunities. And the AASLD IDSA hepatitis C guidelines, certainly one thing to just say out at the outset is that hepatitis C treatment, as in the guidelines, is indicated for all patients living with hepatitis C infection, with the exception of those with short life expectancies that cannot be remediated with rescue options, for example, such as liver transplant. And so the ideal setting is that we try to couple as many things on a single visit to make it convenient for patients and to get patients from diagnosis to evaluation to treatment, ideally done in one setting. So what this means is leveraging in the episodic or point of care test settings, the Hep C RNA point of care test. The one limitation that we still have is the lack of a hepatitis B surface antigen point of care test. But also do HIV screening at the same time. And then also do evaluation either with lab or other procedures such as elastography to do a fibrosis assessment or staging, and then ultimately prescribe direct-acting antivirals. So either giving them a prescription or giving them direct-acting antivirals in hand would be where we want to be moving towards. So doing as much on one encounter with the patient, particularly in point of care settings. So the need for test and treat in settings, again, with high infection burden and or low access should really be priority areas. So recognition of undiagnosed and untreated in particular settings need to be targeted for diagnosis and treatment. And this is really what microelimination efforts typically focus on. So in our groups with injection drug use, justice involved, so Department of Corrections, large jail settings, unstably housed individuals, immigrant communities, rural communities, thinking about how we leverage strategies that can, again, in high infection burden populations and groups and communities that have low traditional access to care, scale up testing and treatment. And so thinking about leveraging and integrating this into opioid treatment programs, syringe service programs as part of harm reduction, but also integration of testing and treatment, opt-out approaches in certain settings such as prisons and jails, leveraging mobile units, clinic settings serving new arrivals, and then leveraging telemedicine as another strategy. So Michigan implemented and launched their hepatitis C elimination plan in April of 2021. And the vision was for Michigan residents to have equitable access to programs and services to prevent the spread of hepatitis C, which will be a curable disease for all. And at that time, Michigan's Hep C prevalence was around 70,000, particularly based on the NHANES sampling estimates. and ranked 7th among all states in the United States in terms of hepatitis C infection burden. And in April of 1st of 2021, the We Treat Hep C initiative was launched, and this was, really the vehicle, right, to eliminate hepatitis C in Michigan to increase, access to hepatitis C treatment. And so Michigan Medicaid had pharmaceutical companies compete for the contract. Mavyret was selected as the preferred medication. And enables treatment with Mavyret available to all Medicaid and Healthy Michigan plan beneficiaries at little to no cost, but also ability to access other direct-acting antivirals through a streamlined, leaner version of a prior authorization process, and approved when Mavyret is not clinically appropriate. And enrollees, regardless of their history of substance use or liver damage, can be cured of hepatitis C through a prescription with any healthcare provider. So really doing away with restrictions on who can prescribe and whether or not patients had to show alcohol and substance use abstinence requirements. So this was certainly something that helped not only put us on the map, but improve really Medicaid access, which is tracked very closely by the National Viral Hepatitis Roundtable, along with the Center for Health Law and Policy Innovations at Harvard, where they actually look at nationally Medicaid access to hepatitis C medications, and then they grade states based on restrictions and requirements that are still in place. And in 2022, Michigan received an updated grade of an A+ rating, given this change and implementation of the hepatitis C elimination plan. So as I mentioned at the beginning, we still see new cases of hepatitis C infection. And rates of acute hepatitis C infection is something that we still see. And between 2010 and 2018, acute hepatitis C infection consistently increased among all age groups. So this is data from the CDC website. You can see it's broken down by different age groups. And what you can see that as of 2022, people between 30 and 39 years of age had the highest number of acute hepatitis C infections, followed by 20 to 29-year-olds and 40 to 49-year-olds. And this really is similar to age groups with the highest rates of fatal overdoses in the United States still. So really thinking about hepatitis C as this opioid-related complication, and what we're seeing with the opioid epidemic, still seeing parallels with infection. Here in Michigan, according to the MDHHS 2023 viral hepatitis annual surveillance report, acute hep C infections have fluctuated between 2010 and 2020, but has since decreased through 2023. The increase here in the number of acute cases in 2016, maybe at least partially responsible for that sharp increase is explained by the change in the acute hep C definition by the CDC. So those increases in 2016 and 2017 are thought to be partially due to that, along with a concurrent hepatitis A outbreak that resulted in an increased number of hepatitis screens being done, potentially increasing hepatitis C infection, and then the reduction in 2019 of cases of acute hep C, according to the report, is likely attributable to introduction of negative hepatitis C RNA electronic lab reporting requirements that were implemented, which reduced the number of probable acute cases. But I think one thing this shows us is that we still have acute infections that happen in Michigan, and that the trends had closely followed published national benchmarks through 2020, but have since indicated a more rapid reduction of acute hepatitis C infection. There are multiple things that might explain that. When we think about this as an area as a gap, and with respect to the guidelines, what do we know about hepatitis C treatment in patients who have acute or recent hepatitis C infection? And this is just a table with several of the studies that have been published to date. And you can see that in the acute setting, what has really been a focus of area of study is whether or not treatment duration can be shortened. Do you need as much treatment in terms of the duration to achieve a cure in patients with recent infection? So you can see that the time period of treatment varies anywhere from 4 to 6 weeks. And what you can see overall, though, is that you have a reduced chance of cure with these abbreviated regimens across most of these studies, as low as 71% in some of the earliest studies. One study of note that was just presented at the CROI meeting this last year was the PURGE-C study presented by Kim and colleagues, which looked at adults with acute hepatitis C infection with or without HIV and treating them with 4 weeks of glycopyrrolate probenecvir or GP. And what they found was that they looked at how successful were they with achieving a cure, and they broke it down by subgroups on the figure on the right. And the overall point here was that there is a reduced SVR or cure rate at 12 weeks of 82 to 86%. So I think based on this and all of the prior studies, the acute hepatitis C treatment recommendations have remained the same in the updated guidance. And this is owing to high efficacy and safety in patients with acute hepatitis C infection. The same regimens that are recommended for chronic hep C infection are recommended for acute infection at this time. Sorry about that. My mouse is a little skittish. The other update to the guidance that is really important to highlight is the changes with respect to determining a cure. So this is thinking about whether or not the time period in which we can determine the cure could be changed or shifted from waiting 12 weeks off treatment to determine cure to a shorter time frame. And the premise for this was that one, there are high rates of patients who are lost to follow-up before coming back 12 weeks after completing treatment. In some settings, this is as high as 62%, despite lots of incentives and navigation and other work that goes into trying to get patients to come back to see if they're cured. And then the other piece, and really important piece of this, was that randomized controlled trials have shown that there's over a 99% concordance in knowing the virus status 4 weeks after stopping treatment, so what we would call a sustained virological response at 4 weeks. And those who are negative at 4 weeks, over 99% go on to have an SVR12 where they're negative at 12 weeks. And most of this is in patients without cirrhosis, again, without prior direct-acting antiviral exposure. And again, so for this reason, all of the major trials were still done with SVR12 as the way the cure was determined. So the grade 1B recommendation is for quantitative hepatitis C RNA testing at 12 weeks or more after completion of direct-acting antiviral therapy to determine cure. But evaluation of SVR at 4 weeks by quantitative hepatitis C RNA can be considered an alternate measure of hepatitis C cure among people without cirrhosis or prior direct-acting antiviral exposure. So I think this is something that's new, really important for us to understand. SVR12 is still recommended, but in settings where that can't be practically done, the SVR4 can be your alternative measure of hepatitis C cure. And again, what is this data based on, or this recommendation based on? This is one such publication which looked at the combined analysis of phase 2 and 3 clinical trial data of patients across several trials for treatment of hepatitis C. Some included compensated cirrhosis, receiving glycopyrrolate and probenecvir. The positive predictive value of the SVR4, again, for achieving SVR12 was over 99%, regardless of the treatment duration. And SVR4 was highly predictive of the SVR12. So this was part of what went into consideration in that updated guidance around SVR4 being an alternative measure for identifying patients who have cured. The other area in which we are certainly starting to see, and with great interest, wanting to see more guidance in hepatitis C in pregnancy, because hepatitis C in pregnancy can impact maternal and infant outcomes. So we know women who have childbearing age who are pregnant living with hepatitis C have increased rates of cholestasis of pregnancy, increased risk of gestational hypertension, increased risk of C-section delivery, increased risk of ICU admission. And we also see infant adverse health outcomes with increased risk of preterm birth, low birth weight, fetal growth restriction, and neonatal ICU admission. So the guidance here, which is important for us to kind of just emphasize, is that in the testing space, again, as part of prenatal care, all pregnant persons should be tested for Hep C with each pregnancy, initially at the initial visit. But in the whom to treat, for women of reproductive age with known Hep C infection, antiviral therapy is recommended before considering pregnancy, whenever practical or feasible, to reduce the risk of transmission to future offspring. But in the kind of the comments and the description under this guidance is that despite the lack of a recommendation, treatment can be considered during pregnancy on an individual basis after a patient-physician discussion about the potential risks and benefit. So the space that's certainly being watched very closely to see if this will further get updated includes studies such as this one, which is the STORK study. Updated data was presented in California last fall at the liver meeting. And this is a study looking at sofosbuvir or velpatasvir for the treatment of hepatitis C during pregnancy. And so interim results from this study were presented. So pregnant women are enrolled between 20 to 30 weeks gestation and initiated on a course of a 12-week treatment regimen of sofosbuvir velpatasvir, and then they're followed to cure. And in addition to the maternal outcomes, they are following and evaluating the infant outcomes, including how many, if any, have adverse events, whether or not they test viral load positive, as well as other factors. And at the data that was presented, you can see the 50 patients were enrolled, 44 have delivered, and 46 completed study medication. 35 have completed an SVR assessment. In terms of the overall patient characteristics, the median age was 32 years of age. 84% had public insurance options. The risk factor was injection drug use, and nearly all, 80% or more. And all of these patients had low fibrosis risk, 92% are indeterminate risk. None were in the high risk, high fibrosis risk category. Many had had hepatitis C with a previous delivery, or more than 50%, which is obviously something that this study and others are seeking to try to address questions around. And what they were able to show was that 35 out of 35 patients who have completed SVR assessment have achieved a cure. So I think we're waiting for additional data from that trial, as well as data that might be collected through the pregnancy registry. That's a global effort, as well as other trials that might be planned. Finally, the last, another final area in which we've seen some updates with the guidelines this past year have been in individuals with a history of HCC or hepatocellular carcinoma, okay, or liver cancer. And there's been some question about the impact of direct-acting antiviral hepatitis C treatment on hepatitis C recurrence or occurrence. And so there was some additional review of the available literature and data. Multiple studies have shown a lower risk for incident liver cancer after a cure with direct-acting antivirals. Reports of unexpectedly high rates of liver cancer recurrence after a cure in the early direct-acting antiviral era raised some concerns about treatment and how does that influence liver cancer risk. There have been several large observational cohort studies that have found direct-acting antiviral therapy is not associated with increased risk of liver cancer recurrence since then. And direct-acting antiviral therapy is associated with a decreased risk for liver decompensation and all-cause mortality. And so for this reason, prior history of liver cancer is not a contraindication to hepatitis C treatment. Furthermore, treating hepatitis C in the setting of liver cancer, there may be some special considerations in terms of the timing of Hep C treatment in the setting of liver cancer. And generally, treatment regimen recommendations are unchanged for those patients without liver cancer. And so there's really insufficient evidence at this time to recommend modification and duration of antiviral therapy or addition of ribavirin based on prior history or current liver cancer. And then in patients who have hepatitis C with early stage liver cancer, expeditious management of liver cancer should be prioritized. So we shouldn't delay liver cancer treatment, especially with respect to considering whether or not to treat the hepatitis C. An achievement of adequate liver cancer treatment prior to hepatitis C treatment might increase your likelihood of a cure. And this is based on observational cohort studies that demonstrate a lower cure rate among individuals with liver cancer compared to those without HCC. And then active liver cancer at the time of direct-acting antiviral initiation is associated with higher odds of direct-acting antiviral treatment failure. And so DAA therapy may be deferred until 4 to 6 months after initial therapy for early stage liver cancer in order to maximize virological response. And then finally, in patients with advanced liver cancer and who are living with hepatitis C, effective therapies for treating advanced liver cancer have really made big strides. Multiple studies show improved survival in patients with advanced HCC and liver cancer. And SVR or cure is associated with improved liver function, better response to first-line liver cancer treatment, and higher likelihood of receiving additional liver cancer treatment. And there's really minimal drug-drug interactions with direct-acting antivirals and liver cancer systemic therapies, which have become a growing modality used in patients with liver cancer that's advanced. So in patients diagnosed with advanced liver cancer who have hepatitis C, should undergo treatment for hep C unless they have palliative goals of care, in which case they might meet those shortened life expectancy without remediation options. The other thing that was published in the last year by the hepatitis C co-chairs of the guideline committee and the guidance panel was thinking about how to incorporate guidance to support elimination in the United States. One area of focus in this paper was to really think about how we can support hepatitis C test and treat algorithms. And so to that end, additional kind of considerations have been given. So we know that several years ago, hepatitis C treatment was simplified, particularly among those with treatment naive, without cirrhosis, with pangenotypic regimen availability. One of the limitations of this has still been, it's been difficult to achieve simplified treatment, even in kind of our non-traditional, non-longitudinal care settings, presenting challenges. And while we've also had simplification, so fibrosis assessment is still needed to be done for all patients so that we don't miss cirrhosis, and that's such an important point to still keep in mind. But we no longer need genotype. Knowing the treatment prior history, knowing drug-drug interactions and comorbidities can be helpful in terms of selecting regimens. But one major gap here, especially with the advances in diagnostics, is this does not incorporate point-of-care testing that is now available. And then finally, when we think about the approach to management of hep C, we still have patients who have to walk through different steps from screening to then moving to pre-treatment assessment and then treatment and monitoring. And this is the limitation here is that it requires at least 2 trips to see providers, often more. And so to that end, the guidelines have been updated with a hepatitis C test and treat algorithm. And so this is broken down into 2 parts. The first is with respect to the initial visit and initiation of treatment. This now incorporates point of care testing or traditional venipuncture to be used. And again, thinking through longitudinal care settings versus episodic care settings or point of care settings to leverage which test for the best setting, including pregnancy testing, if appropriate, and HIV testing. There's confirmed infection, again, where your point of care testing can be helpful here. You then want to know if they've been treated before. Do you know their hepatitis B surface antigen status? Do they have known liver cancer? And or do they have clinical evidence of any decompensation in their liver disease? And if, depending on if they're yes or no, Then patients get stratified to move towards, if again, you don't know, for example, their hepatitis B surface antigen positive, their status, you can still do medication reconciliation. You can still prescribe medications or consider prescribing at the initial visit, draw their labs, okay, that would let you allow you to do a fibrosis assessment, such as a FIB4, and also get the hepatitis B surface antigen test done at that time. You can have shared decision-making, discussion of risks of hepatitis B co-infection, and then instruct patients to either start medication and that they'll be contacted about their hepatitis B surface antigen status, and initiate treatment with GP for 8 weeks or soft valpattosfere for 12 weeks. And then it's super important to still follow up on the hepatitis B test. And depending on the status, knowing whether or not if they are Hep B infected, monitoring and referring to a specialist for long-term hepatitis B management. If you already know their status and they have a history of hepatitis B infection with the surface antigen positive, meaning they likely have chronic infection, previously treated, known liver cancer, consider a specialty consultation to evaluate patients further. I think the big change here with this test and treat algorithm is that it provides guidance for immediate treatment or treatment after the surface antigen results are obtained. So I think the important factor here is thinking through that we now have some guidance to help us try to move patients towards treatment faster and sooner, and ways in which providers can figure out what they're most comfortable with and tailor. That's to initiate treatment, right? But then there's also the follow-up piece of things, and there's an algorithm that's been developed and on the IDSA ASLD hepatitis C guideline website. So again, I think when you think about what's new here is the option for an earlier assessment of SVR. You know, SVR 12 is still has the highest recommendation and evidence, but we know that SVR 4 and SVR 12 have high concordance. We know that there's a risk of lack of follow-up, and so our Hep C RNA at 4 weeks after completion of therapy is the one thing that's been added new here. And then finally, among patients who have advanced fibrosis prior to treatment, it's still really important that those patients get monitored for risks. So based on your pre-treatment FIB4 or elastography, whatever your fibrosis assessment, needing, if they need liver cancer screening, you know, because they have an elevated FIB4, varicose screening. And then also in your patients who are cured of hepatitis C, we know that metabolic factors and alcohol have increased risks in this population of patients living with hepatitis C. So in terms of the long-term risks for liver disease progression, thinking about other concomitant, you know, post-cure factors that need to be put into the equation and monitor patients, since those are growing entities. You know, MASLD and alcohol-related liver disease are now leading indications for etiologies of liver disease. And then finally, it is worth highlighting also that community-based point-of-care diagnostic treatment, particularly in populations that have access challenges to treatment. This was a nice study that was published by Dr. Price's group, the No One Waits Now study, which was a single-arm, non-randomized controlled trial conducted in San Francisco via street outreach recruitment between July 2020 and October of 2021. And what they were able to show in an urban US population with high rates of unstable housing and injection drug use, there is a pathway leveraging point-of-care testing and quick starts of treatment to get patients with high rates of SVR. So in terms of the guidance updates, you know, again, acute hepatitis C infection is the same as chronic hepatitis C infection in terms of treatment duration. Results of abbreviated acute hepatitis C demonstrate that some can achieve an SVR, but it's lower than with a standard course of chronic Hep C infection treatment. SVR4 can now be considered as determination of SVR 12. Hep C treatment studies in pregnancy are ongoing and can be considered on a case-by-case basis with shared decision-making. Hep C treatment can be given with 2 patients with liver cancer, and point-of-care Hep C RNA tests are now FDA approved and can be used in many settings. So I'm just going to end with a couple last slides so we can take some questions. You heard a little bit about the open program at University of Michigan. We actually added hepatitis C services in October of 2020, initially through Michigan Opioid Collaborative, which has been kind of integrated into open. It allows for online case submission with a response typically from me within 48 hours. And the goal is to really just support treating hepatitis C where patients are already being cared for in the community. It's been a really beautiful way for me to meet a lot of providers working in rural parts of the state. We receive 2 to 4 consults per month. Some common questions that we've been able to help people answer include things like, does this patient have cirrhosis based on this FIB4? I don't have the hepatitis B surface antigen labs drawn yet. Can I start treatment? A patient previously treated and now reinfected. What should I treat them with? My patient is taking a medication that is a potential drug-drug interaction. How should I proceed? And then I have had a patient who's had prior incomplete treatment. How should I proceed with this patient? So these are just some samples of questions we help people walk through. And then finally, if you think about what's the national road to how we get to elimination, it's to expand testing, think about how we leverage these new advances in point of care tests and application in high prevalence settings. Needs to be coupled to high treatment initiation to be cost effective. How do we still work to lower drug costs and remove barriers to access through our national funded hepatitis C plan, expand infrastructure for test and treat programs, includes integration with opioid use treatment programs and syringe service programs, expand harm reduction services, bolster surveillance, and certainly we're still keeping an eye on advances in vaccine development. So I'll end with rethinking the role of the specialist is what I've certainly had to really think about over the course of my career. Specialists are really supportive rather than primary actors in eliminating Hep C. There may be training gaps we can help fill. We can help be capacity builders. We can still be treaters, but really for patients, focused patients with liver cancer, decompensated cirrhosis, transplant recipients, some treatment failures, and thinking about how do we simplify our guidance to increase adoption and adherence even more as we move forward, and then still continue to advocate for this national elimination plan.
Also, the information for the continuing education credits is also up. That will also be emailed after the presentation if you don't get it taken care of right now. We did have a few questions get put in the Q&A. So are there specific treatment recommendations for individuals co-infected with HIV and HCV? If both conditions are currently untreated for a patient, does treatment initiation for one take priority over the other?
I'd say in general, no, there aren't lots of special considerations anymore. You're seeing a lot of the studies still being done with and without HIV. I think the important thing is that all patients who have risk factors are getting tested, right, and then move towards treatment. So it's still important in our patients with HIV to be addressing the HIV. So these are things obviously to be concurrently doing with our patients. But HIV needs chronic management, hepatitis C needs treatment. So you just need to keep your eye on the ball of getting both of those addressed.
Also, if anyone has any additional questions or comments, you can feel free to raise your hand and we can unmute you. So another question is, can you clarify AASLD's current guidance on SVR12 versus SVR4? I see it says consider. Do we anticipate them going to SVR12 across all their guidance?
So the guidance is based on what evidence is out there, and that is deliberated upon by a panel. And so it's hard for me to say what the future holds. But based on the data that's available now, the SVR12 is still recommended with a stronger level of evidence, mostly because that's how the clinical trials, the RCTs, the highest level of evidence that we can generate, we're kind of grounded on with that primary outcome. But there's now been, as I mentioned, the additional observational studies and pooling of data across clinical trials to look at how SVR4 tracks with SVR12. So it's an alternative measure is what the guidance provides. And I just don't know what the future would hold in terms of what new studies will come out and how the guidance will change.
Okay, and yep, Sonia, you should be able to unmute yourself and ask your question.
Yeah, I just wanted to know if a person they get reinfected, once they've been cured, they get reinfected. Is everything accelerated or is it like a first time infection or is it accelerated symptoms once they
Yeah, so
reinfected?
that's a really good question. And it's important to think about retreatment on anybody who's infected or reinfected. And retreatment options when it's a second new infection, follows the guidance of like the first infection. So, and if you go to the website, you can see how to navigate to the reinfection recommendations. In terms of accelerated fibrosis, obviously each infection potentially leaves a footprint, right, in terms of fibrosis risk with the liver. And so the longer that a patient has chronic hepatitis C infection, the more fibrosis risk they have. But I think the bigger issue for like a patient like that is just continuing to offer opioid use disorder treatment, harm reduction when and where appropriate, so that they can really reduce their chances for reinfection. But we need to address the reinfections, and so they should be treated. And treatment typically follows like initial treatment. I hope that answers the question.
Yes.
Right. Is it true that buprenorphine stays in a positive HCV individual 3 weeks or longer than an individual without HCV?
I have not heard that before. Yeah, so I don't know the answer to that question. We could get back to the person on that one. I see it in the chat.
Sonia, did you have something else you
I
wanted?
do. I wanted to know, since this is such an epidemic, why aren't they lowering the costs where, I heard you say at first that uh, some people can't afford it. So, I mean, is the government is involved? Is it they're doing something on a national level to lower the cost so everybody can be treated?
So the answer is right now, we need to be doing more. The National Hepatitis C Elimination Plan builds in improving access and affordability to medications. So what has been looked at are the states that have subscription models, for example, where it really encourages state and county health departments to really be doing more treatment for the amount of money that you pay up front. So they're looking in the White House elimination budget proposal that's kind of baked into reducing the cost, particularly potentially with Medicaid, and trying to explore what can be done. So it is a real problem, Sonia. I agree with you. The cost is very high. I think I showed you the treatment rates, are lowest among people with Medicaid, followed by Medicare. And among those that are not insured, we really don't have good options outside of occasional foundations that have, like, I've seen these foundation trusts open for like 24 hours where you're able to act. I've had
Right.
actually some providers I've worked with in Michigan who have been able to access treatment through those foundations. But those are few and far between, and they're not going to get us to elimination. So yeah, I agree. Lots more needs to be done to reduce the cost. And that's, I think, a big part of what this nationally funded Hep C elimination plan would hopefully get us towards.
Okay.
What would a discussion of risks and benefits of treatment during pregnancy need to include?
Yeah, so I think it's it like based on what limited data that we have. that it hasn't been yet well studied in pregnancy, so we don't know what the risks are. There's obviously, I think, pluses and minuses, obviously, that we are challenged with every day in terms of insurance coverage during pregnancy, engagement in health care during pregnancy, and weighing that against like the unknown. I think we're going to have more data from the Stork trial soon, particularly with respect to maternal and infant outcomes. And so hopefully this guidance gets informed by additional evidence that gets generated. But it's just that we have very limited experience right now. And so, in terms of answering all of the safety questions, like, for example, that come up when we're counseling women, particularly in pregnancy, because it's safety to the individual and safety to the baby, right? So there's kind of like it's a little bit more complicated. So they're just things we just don't know yet until we have more evidence. So despite that, some people might opt, and in those patients, that's where the shared decision-making comes from. So that we just really have limited data. We have some early data showing that we're able to cure in these small trials, right? Yeah. So I think it's just based on what we have, which is somewhat limited.
For those of us who work in microsocial work, how can we advocate for the National Hep C Elimination Initiative and work to reduce stigma in the spaces we work in?
Okay, I love this question. So, like our professional society every year does a Capitol Hill Hepatitis C a Capitol Hill like advocacy day. What was huge on the main big front and center kind of ask was to advocate around the Hep C National Elimination Plan. So in March, many of us met with local representatives. It's always open to anybody in Michigan to join us. We typically have that in March, but you can meet with us, and we meet with like staffers from our senators and congressional representatives offices to talk about the plan, put it on their radar, keep it on their radar, let them know, when the bill was introduced, where we are with, for example, the CBO scoring process. Outside of that, even if you didn't want to join for like next March when we have this, you can always call your state representatives and let them know that there is a hepatitis C elimination bill that has been initially introduced, and I'm happy to actually share some additional resources, Katrina and Sarah. Maybe we can actually put those advocacy resources so that people have some talking points if they wanted to. They are from our professional society, but they give you a little bit more background. So I'll just have to get some permission, but I'm happy to share that. But I think talking to your local representatives that you want to see this national plan realized is how, in part, the advocacy piece of it will work. I think there's just generally speaking bipartisan support for the bill that was initially introduced. And so I think people are still very hopeful, even with like change in congressional representatives and folks in the White House, that this will still have, legs and traction. And so we'll see where it goes.
Happy to share that information.
Yeah. So I think we are getting very close on time. Oh, there's one more question in there. Says I'm not able to click the links on the survey. We will send the information out in an email, so you will get it and be able to take the survey that way if anyone's having trouble using the slides. So thank you again, Pawnee, for a wonderful discussion and presentation, and thank you to everyone who joined us. We will be sending information out after the webinar today. And if you have any more questions, feel free to reach out to us. And I hope everyone has a good afternoon.